Hello and good evening, everyone. Welcome to our 45th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Yeno Tadele, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's a pleasure to have Dr. Major Pankaj here with us to give a session on endoscopic spine surgeries and merits of posterior lumbar interbody fusion. Dr. Major is an FIPP qualified from Budapest, Hungary, and World Institute of Pain. He is a certified interventional spine and pain specialist. He is accredited by many pain societies, both national and international, and he is a member of them. He is the ex-chairman of World Institute of Pain, India chapter, and a honorary secretary of Indian Society for the Study of Pain. He is an alumni of Indian School of Business, where he did his advanced healthcare management program. And Dr. Major has a special interest in expertise in advanced spine interventions, endoscopic spine procedures, and vertebral augmentations. He is the CEO at Interventional Pain and Spine Center.
So I just wanted to mention that this session is also presented by one of our partners, HBG company. So we need to mention that also. And Dr. Kritika, maybe if you have something that you want to mention, maybe I'll give you a 30 seconds or a minute. After that, maybe you can take it back to Dr. Pankaj.
Sure. Thank you so much, Adam. Thank you for this. So I'm Dr. Kritika. I'm representing HBG Medical Assistants. It's the India's most well-known medical assistance company. And it is a brand which is owned by India's biggest home sample collection company, which is a diagnostic company. Until date, we have assisted 10,000 plus patients. And thank you. I'm very glad that we are partnered with Blue Health Ethiopia and we are doing these seminars, these webinars. I'm looking forward with more webinars, and I'll give the stage back to Dr. Pankaj. Dr. Pankaj, you can start your webinar now.
Thank you, Kritika. Thank you, Dr. Yana. And good evening to all of you, all the participants here. So I'll take you to this. So today what we are going to talk about is that minimally invasive interventions. So we all know that in every part of the world, every countries, every cities, we all know that as a practitioner, as a medical professional, we know that pain is the first complaint which patient complains of, right? Whenever patient comes to you, most of the 70% of the patient comes to you with the pain. And out of that pain, the most common pain patient complains of is the back pain or the neck pain or the joint pains. So today we are going to cover the spinal pains and what all advancement are there in the management of the spinal pain, especially with the chronic pains. So when we say chronic pains, that means a person who is suffering from pain for more than 6 weeks or 3 months. Some society says 6 weeks, some says it is 3 months. So anybody who's suffering from acute pains, when we say acute pains, means like a muscular pain, suddenly lifted something, and muscle spasm is there. So these are the acute pains. So we'll not discuss those acute pains, but we are going to discuss what we can do best for our patients who are suffering from chronic spinal pains. So MIPSI is the name given to these procedures, that is called minimally invasive pain and spine interventions. So interventions, as we all know, what are interventions? These are minimally invasive procedures. The biggest example of the intervention everybody knows about that is the interventional cardiology. So earlier we were doing open heart surgeries for the blockages, and now we can do with the interventional cardiology, we can do stenting, we can open the blocks, we can put stents inside. So this is the intervention, which is the minimally invasive techniques. So similarly, we can do something for the spine. where we don't have to open the spine, and we can do percutaneous procedures to basically alleviate the pain of these patients. So I'll take you through this. This is the basically step ladder approach, what we normally use at our center at IPSC. We use a step ladder approach to managing the pain, spine interventions. So those patients who come with the acute pains, we usually manage them with the physiotherapy, rehabilitation, or the pharmacotherapy in the form of medications. If they don't respond to that, in those cases, we can go switch to the minimally invasive interventions. If that is also not responding, or the patient is critical, like the patient is having critical stenosis, in those cases, we can go directly for the surgical interventions. Now, even in the surgical interventions, we can do percutaneous fixations and other endoscopic fusion surgeries. If the patient is still not responding to that, or the surgical surgeries have failed, or patient is not responding to surgery, in those cases, we have some advanced interventions also that we'll discuss today. So this is the step ladder approach, what we follow in our hospital. So if you look at this MRIs, so this is what is the beauty of these intervention. Any patient comes to us with the spine or the back problem, every patient is having a typical different pathology. It is not that every patient coming with the back pain is having the same pathology. The most common, what we think about back pain is a slip disc, but that is not the cause. Slip disc as a cause of the back pain is just 2 to 5% cases. In 90 to 95% cases, these are some other causes which are the source of the pain in the spine. Now, if you look at these MRIs, so these are all the sagittal sections of the spine, and you can see different pathologies here. If you look at here, there's a big tear over here in the annulus. So this is the most common cause of chronic back pain, especially in the younger population. So you must have come across patients who are in their young age, those who have long sitting hours, long driving hours. They come to you with the back pain and they say, when I sit for 30 minutes, 20 minutes, I start getting pain. My back becomes stiff, right? And then when I start moving, I feel better. Or they may say that when I wake up in the morning, my back is totally stiff. It is difficult for me to get out of the bed for some time. And after some time, when I start moving, I start doing my exercise, I start doing my regular activities, I feel better. So this is the most common reason for these such kind of chronic back pain with stiffness, especially in the younger population. This is called the annular tear. Now, if you look at this MRI, in this, we can see a very small herniation over here. Now, this is very important to understand. These are the patients where you may see on MRI a very small herniation, but the patient may be complaining of back pain and radicular pain also. Now, if you look at the MRI different sections, you may see, or it may be reported that there is hardly any compression of the nerve. So this is very common mistake. What we do is we just rely on the MRI reports. What happens, because this MRI is taken in the supine position, in the lying position, in a resting position. So in that position, this herniation may not be significant. But these are the patients who will say that when I start walking, after walking 10 minutes, 15 minutes, I start getting radicular pain. That means the pain goes down to my leg. So why this happens? Because there's a tear over here, there's a herniation over here. This part of the annulus is weak. So when they start walking, or if they stand for a long time, what will happen? There's a pressure which develops over here, and this herniation will start protruding like this. And that will start compressing the nerve. And when they sit down for some time, they feel better. So this is typical of the contained disc herniation. This is called a contained disc herniation. Now look at this condition. There is hardly any herniation over here. And if you just compare with this disc over here, it is very well hydrated. It's a normal disc. But this is looking dark disc. So these are the patients who are complaining of, again, the discogenic pains. They will have more of the back pain than the leg pain or the radicular pain. So this is because of the disc degeneration. This is another very important source of the pain, most common cause of the back pain. Look at this, there's a herniation over here, moderately large herniation, moderately large herniation. that this may be compressing the nerve. When they start walking, if they bend forward, this will herniate more. It will start compressing the nerve over there. This is a big extruded disc over here. This is extrusion, and this is called a sequestration, which is migrated downwards also. So all these patients, these are just a simple example, 6 example, but you may get a multiple combination of these patients. So all these MRIs, if I have to treat these patients, all these patients will have a different pathology, will have a different choice of intervention or different type of procedure which we're going to do on these patients. So we'll discuss that, what all we can do for this kind of patient. So every patient with a back pain or the leg pain is not same. They have a different pathology. They have a different interventions to deal with. So bicoplasty is a spinal disc repair procedure where we use a technology which is called a cooled radiofrequency technology. This is a relatively new technology. We have been using since last 7 years now. We have found excellent results on the patients who are having only back pain, especially in the younger population. So this is the kind of disc what we can see here. Now, if you can appreciate here, if you look at this disc over here, if you look at the disc, the annulus is intact, the disc is filled with the jelly material, which is very well hydrated. So this is a normal disc. This is also looking a normal disc. But what is happening over here? There's a big tear over here. If you can appreciate that, this is a big tear over here. So this tear is basically causing the pain. If you look at the same MRI in the axial section, you can see there's a big tear over here. So this is a tear which is causing the pain. So whenever there's a pressure on the disc, this will start herniating over here. So in these cases, what we can do annuloplasty. It's called annuloplasty. That means we can repair the disc. Now we don't have to fix the spine for these kind of discogenic pains or the annular tears. Earlier, what we used to do, we used to fix the spine so that there's hardly any movement over here and the patient will feel better. But for that, you have to open the spine, you have to put implants inside, and it's a major surgery. Especially in the younger population, we cannot let them undergo these kind of surgeries for such a small problem. Now, these kind of tears we can manage with the bicoplasty, which is why it is called bicoplasty, because we do it from both the sides. We have to go from both the sides, and we use a radio frequency over here. So this radio frequency, what it will do, it will create a granulation tissue over here. So when we go inside like this from both the sides, we create a lesion over here. So this lesion will heal on its own gradually over a period of 3 to 4 weeks, and this will be replaced with the fibrous tissue. So this entire tear will be replaced by the fibrous tissue. As we know, wherever there's an injury, let's say we have a skin injury, it is replaced with the skin and the fibrous tissue. Same thing is happening over here inside also. So we are creating a fibrous tissue so that this part gets healed and this becomes solid, this becomes strong, so that this doesn't go out, this doesn't herniate from here. So this is the procedure which is called the bicoplasty. It's a percutaneous procedure. You can see these are the probes which goes inside the small holes. So small will go, and this is the fluoroscopic guided procedure. And these are the procedures we do under local anesthesia. So this takes around 45 minutes to 1 hour. The procedure time is 45 to 1 hour. We can do at 1 level, we can do at 2 level, we can do at multiple level, but it is always recommended not to do more than 2 level in one go. So this is the kind of fluoroscopy what we use. I'm sure that everybody knows about this fluoroscopy. So this is a fluoroscopy guided. We can see everything inside, and we can put the cannulas with these probes inside, and we can do the lesioning over there. If you have a condition like this, which I explained about the contained herniation, disc is well hydrated. Hydration is good, but it is small herniation is there. It's a contained herniation. So these are the patients who will come to you with the, when they start walking, they will have regular pain. Because when they start walking, when they stand for some time, if they sit for a long time, what will happen? This part will start herniating over here because this portion is weak. So it will start herniating, it will start compressing the nerve. So in these cases, since the annulus is intact, we don't want to decompress the disc, we don't want to touch the annulus, we don't want to disturb the annulus. We want to preserve the anatomy. We want to preserve the annulus. So in such cases, what we can do is, because it's a very small herniation, hydration is good. In these cases, we can go with the ozonucleases. Ozonucleases basically helps in the shrinkage of the disc. So in this, we are not removing any part of the disc. We are just shrinking the disc over there. So this is a very short procedure. We can go inside like this under fluoroscopy guidance, and we can inject ozone inside. So ozone, what it does is that it basically breaks the proteoglycans. As we know that nucleus pulposus has proteoglycans, these proteoglycans are responsible to hold the water inside. So this water gives the hydration to the disc. So when we break the proteoglycans with the ozone, they start dehydrating. And in the meantime, what will happen? This disc will start shrinking. So this is a procedure which is again a day care procedure. We do it under local anesthesia, and this doesn't require any cutting of the bone and the cutting of the ligaments or the annulus. So we can preserve the annulus. We just have to shrink the disc, and that will basically offload the nerves which are compressed with the herniation. If you have a disc herniation, which is small herniation, and hydration is not good, obviously ozone is not going to work here. In those cases, we can do percutaneous disc decompression. That means we can go with this kind of probe. It's a rotating probe. If you look at this tip, it's a rotating probe. We can go inside and we can remove some material from here, from the center of the disc. So what happens when we remove some material from the center of the disc, we are creating some space inside the disc. Now the annulus, it has a property to retract. So when we create some space inside, the annulus will retract, and that will cause again the shrinkage of the disc material, and that will offload the nerve. So this is another procedure which we can do for the contained herniation when the hydration is not good and the herniation is small. So in these cases, we can use these kind of technology where we can decompress the disc from the center, and the disc will retract on its own over a period of 3 to 4 weeks. If you have contained large disc herniation, if you look at here, it's a very big herniation over here, right? If you look at this axial section, this is the right side nerve root, but this side, if you look at here, there's a big compression over here. There's a big compression. So this is a compressing. This is in a supine position, in a resting position. When you take the MRI, you can see this compression over here. So these are the patients, or the patient if they're having extruded disc. That means if the disc material has come out, it is not within the annulus now. It has come out like this. That means the outer annulus is not intact now. The disc material has come out. That is called an extruded disc. So in this case, still it is in continuity with the parent disc. And then another is the sequestration. Sequestration means it has come out and it is lying somewhere else in the canal. It is detached from the parent disc, and it is the nucleus material is lying somewhere else. So that is called sequestration of the disc. So obviously in these conditions where we have a very large herniation compressing the nerve, if it is extruded disc or if it is a sequestrated disc, there is no point of going inside the disc and shrinking the disc. Because even if you remove the disc material from here, even if you want to shrink the disc over here, it will not have any effect on these extruded or the sequestrated material, right? So this part will remain there. So in these cases, what is our target? Our target is to remove the disc material from here, from the canal. So in such cases, what we can do is we can go for the endoscopic disc decompression. So again, it's a keyhole procedure. Very small incision is given, just a 1 centimeter incision is given. Through that, we go inside. We can see everything on the screen. First, we have to go with the fluoroscopy guidance, and then when we put our scope inside, we can see everything inside, and we can do this procedure under local anesthesia. So there are multiple approaches for endoscopic discectomy. There's called inside-out technique and outside-in technique. I'll not go too much into technical details of these endoscopic procedures. What I'm just going to show you is that what is the difference between outside-in and inside-out technique. Look at this patient. This patient is having 3 pathologies. This is the one, there's a tear over here. That means the annular tear. There's hardly any herniation, but the annulus is not intact. There's a tear over here. In this, it has already sequestrated. It has come out It is lying into the canal. And this is a contained herniation. So if I have to do procedure in this patient at all the 3 levels are having different pathologies. If the patient is having pain coming from all the 3 pathologies, we had to address them separately. We cannot apply one single procedure for all these kind of disc herniations or the disc pathologies in the same patient. So if you have this patient is having pain from here, we can do annuloplasty in this patient. If this is a herniation, this is causing the pain, in that case, we can go for the ozonotraces or we can go for the percutaneous disc decompression. But for this case, we have to go for the endoscopic procedure and we have to target a fragment over here. This is a big fragment which is lying over here. So these are the various approaches depending on the site of the herniation. As we know that the multiple sites of herniation, when we say central herniation, the paracentral herniation, the foraminal herniation, and the extraforaminal herniation. So these are the herniation which you can see on the axial sections and the sagittal sections of the MRI. And depending on that, we choose our approach. So it is not that any patient who comes to me with the disc herniation, I will go inside and I'll start decompressing the disc from here. There is no point of doing it that. We had to target the fragments. That means the material which is lying outside, we have to target that. We want to preserve the disc. Whatever the disc is there, we want to preserve that. So that is why we call it a fragmentectomy. That means we are removing the fragment only. So these are the various approaches. Extraforaminal approach, that is for the far lateral disc, like this. If you have to remove this, we can go for the far lateral disc. We can do extraforaminal approach. Transforaminal approach, these are done for these kind of discs: foraminal disc, central disc, superior migrated, inferior migrated disc, and the interlaminar approach, especially for the L5S1 disc. So this is the L5S1. L5S1 is difficult to enter if there is a central herniation. It is difficult to enter through the endoscope because we have a iliac crest over here. This iliac crest will not allow us to go inside, or it may be allow us only to go to the foramen and to the paracentral area, but this may not allow us to go inside into the central part. So in such cases, we can go for the interlaminar approach. Interlaminar means we are going between the laminar process over here. Instead of going like this to the foramen, we are taking this approach. We are going inside and we are removing the disc material from here. So this is the coronal section, MRI section, which is important for us when we do interlaminar approach, where we can see the disc herniation. Suppose there's a herniation over here. We know this is my entry point. If the herniation is here, we will shift our entry point over here. So depending on the type of the herniation and where is the nerve root lying. So depending on that, we will choose our entry point, because initially when we do endoscopic procedure, our entry point is under fluoroscopic guidance. So when we do under fluoroscopic or the X-ray guidance, we don't know where is the herniation. We don't know where is the nerve root, right? So that is why it is very important for us to understand the MRI very well. So once we know the MRI, once we see the fragment, where it is lying, depending on that, we can choose our entry point. Now look at this. This is the herniation over a shoulder herniation. This is called a ventral herniation. This is an axillary herniation, and this is a central herniation. So if I have to address these kind of herniation through the interlaminar approach, we will have to select our entry point depending on the where is the herniation. This is how we do it under fluoroscopy guidance. First, we identify the interlaminar space. It's 22 hours. This is another method which I usually follow, is that I put a contrast inside through the foramen. I see the nerve roots so that I know that where is the safe entry point for me. So this is how we put a contrast and we can see the nerve roots. So suppose there's a herniation over here. I know this nerve is lying over here, so I can start selecting it from here. So these are the kind of some modification we can do to be little safe for the endoscopic procedure. So this is what I was telling you. If my herniation is in the shoulder type, it is somewhere here. I will enter over here. If it is downward migrated over here, we can select it, the entry point over here. If it is in the central herniation, in that case, we can go like this, starting from the lateral to towards the center. You can see over here, this is, so once we go with the fluoroscopy guidance, we put a scope inside, we reach there, and then we put a scope inside, and then we can start removing the muscle layer over there. And the moment we clear everything, then we start seeing the ligamentum flavum. So this is the ligamentum flavum over here. So this is a protective layer for us. So we should not breach this before we put our scope. So that is very important when we do the endoscopic, interlaminar endoscopic. We should be restricting ourselves to the ligamentum flavum. Once we start seeing the flavum, then we should start cutting the ligamentum flavum, and then we can start going inside. So you can see by side, we are seeing also into the fluoroscope where we are. And this is the hole which is made on the ligamentum flavum, and then we have entered inside. And once we go inside, then we can start seeing that there's a fragment over here, and we can catch the fragment and we can remove the fragment from there. The patient will have little pain over here. So when we start extracting, then we start removing the this material, oxidate this material, patient will complain of little bit of pain that time, because as I already mentioned you, these procedures we do under local anesthesia. Till the time we reach enter inside, patient will not feel any pain. But when you start removing this material, the patient will have a little bit of pain, because, and that is good for us. Why we want to be our patients to be awake? Because if you are touching the nerve, patient will complain of pain. So that is a safety measure why we don't want to give any general anesthesia to these patients. So this is a very good safety measure. Why the patient will feel pain at the time of removing this material? Because when we remove this material, we know that whenever the disc comes out, it starts sticking to the nucleus, it starts sticking to the nerve roots, and that is why when we take them out, the patient will have some retraction of the nerve, and patient will complain of pain at that time. So I'll show you some of the another cases, like you can see here. This is a big extrusion over here. If you can make out, there's a big extrusion. You can see on the right side, there's a nerve root which is free. This is nerve root which is free. This is a dura over here. And this is the extruded material which is compressing the nerve, severe compression of the nerve. So once I know that this is a foraminal and a paracentral herniation, in this case, we can go transforaminally. We don't have to go interlaminar. We can go transforaminal approach. So this is how we do it under fluoroscopy guidance. We know that our disc material is lying over here. This is the area where the disc material is lying that we have identified on the MRI. So on MRI, I have identified the disc material is lying here. Now under fluoroscopy guidance, I'll go inside like this to the needle. So this is an introdistal needle, which first we go inside. We put a guide wire inside over the needle. And then we start putting the contrast. We see the contrast inside that we are targeting the proper disc. Over that guide wire, we put a dilator inside. This is a dilator. This is an area where the extruded material is lying. So I know that I don't have to go inside the disc. I just have to target the fragment which is lying into the canal. This is the beauty of these procedure, that we don't have to disturb the entire disc. We don't have to cut the bones over here. We don't have to cut the ligaments over here. These are protective layers of the spine. So we want to preserve them. So this is how we go with this. This is a dilator, and through that we are putting a working channel inside. So that's a working channel which goes inside. And through that we put our scope. So this is a scope which is going inside now. So where is my working channel now? My working channel is exactly sitting over the extruded material. So this is where the extruded material lying, which we saw on the MRI. So when you put a scope inside, then you can start seeing these extruded material, and we can just catch hold this extruded material and we can remove them. So you heard about the pain. Patient who complained of pain at the time, and we can see here, this is the extruded material which has come out completely. This is another case you can see here. There's a big herniation, foramen herniation. You can see over here. This is another foramen. You can see the nerve root, free nerve root. You can see the nerve root here, free nerve root, surrounded by the epidural fat. But here what is happening is there's a big herniation and it is compressing the nerve root completely. So again, we can see here, this is lying in the foramen. We don't have to enter inside the disc. We don't have to cut the nerves. We don't have to remove the disc material from here. We want to preserve the disc. So in this case, what we'll do, we'll just go into the foramen and we'll just remove it from there. So this is how we enter into the foramen, and you can see how big material just come out. On the table itself, it is saying that I'm feeling better. You can see that the just come out. So these are the few other examples. I'll not show the videos of these. This is another herniation. This is a post-operative MRI. This is a big herniation which is going and it has migrated upwards. This is migrated upwards. So we can go inside. Look at this. So what we have done is we have just removed this material from here. We have preserved the entire disc. We have not disturbed the entire disc. Now this is the advanced intervention. It is called spinal cord stimulator. We also call it a pacemaker for the spine. So these are the advanced procedures. These are the implantable devices which we can put inside the body, and patient can control his or her own pain. So these are the implantable devices we use only in those cases which are resistant to any conservative or the surgical interventions. So when the patient has failed multiple surgeries or the patient is not a candidate for the surgery, in those cases, we can use these kind of implantable devices where we basically not try to address the main pathology, but we try to control the pain of the patient. So you must have heard about the arachnoiditis patient. You must have heard about the failed back syndrome patients. You must have heard about the neuropathy. So these are the patients, most common indication of this failed back syndrome. So the patient has undergone surgery, one surgery, second surgery, third surgery, and the patient is having severe radicular pain throughout the day, night. Patient is having severe pains. So these are the patients who are converted from the acute to chronic and to the neuropathic pain. So now what is happening in these patients, it is the nerve itself which is generating the pain now. It's not the compression which is generating the pain. It is not other pathologies, but it is the pathology of the nerve itself which is generating the pain. Now in these patients, further surgeries or further interventions are not going to help. So these are the patients who will respond to these kind of interventions. So this acts on the principle of gate control theory. We all have read about the gate control theory. So when the gate control therapy is what? It basically controls the pain. So that means whenever we stimulate the larger diameter fibers, like paresthesia or the pressure signals or the temperature signals, what will happen? It will stop the pain signals to reach to the brain. So that is called a gate control theory. So this spinal cord stimulator works exactly on this principle. In this, what we do is we put the leads inside into the epidural space, just behind the spinal cord. So these leads are fitted to this pulse generator. So this pulse generator, will deliver a very fine frequency current to the spinal cord. So what will happen to the spinal cord? The spinal cord, as we know, that it is carrying the pain signals to the thalamus and to the cortex. So when we put the leads over here, these leads, when we stimulate them, these will stop the pain signals over here. And what the patient will feel is some paresthesia. So pain will stop, but the pain is converted into paresthesia signals. That is exactly what we do with these kind of spinal cord stimulators. So for the patient who is having severe pain throughout the day, night, 24 hours, this is actually a boon for these kind of patients. They may feel some paresthesia, which may be discomfort to some patient, but usually they adopt these kind of paresthesia signals. Nowadays, we also have some advancement in the spinal cord stimulator. This is called a burst stimulations. Now these burst stimulation in these patients don't even feel paresthesia signals. Patient won't feel anything. Only thing what will happen is that their pain will stop over here in the spinal cord. So depending on the level of the pain, if the patient is having bilateral limb pains, lower limb pain. In those cases, we put these leads in the dorsal spine. If the patient is having upper limb pains, in those cases, we put them in the spinal cord in the cervical region. So this is a very higher advanced technology where we basically are able to control their pain by 50 to 60%. We cannot say that it is 100%. The beauty of this is that patient can control their own pain. They have a remote control with them. They can switch it on anytime. They can switch it off anytime. They can increase their current. They can decrease their current depending on the level of the severity of the pain. Vertebral augmentation. This is another spine procedure. We know that there are patients who come with the compression fractures. We all have heard about the vertebroplasties and the kyphoplasty, which are used for the osteoporotic fractures. But we have advanced in that also. Now we can do these target specific intervention that is called targeted cementoplasty. Now these are the patients who are having big cleft fractures where vertebroplasty may not be possible. If you try to fill the entire vertebral body, in that case, chances of leakage of the cement are very high. So that is why we have selected these targeted cementoplasty. Now we started doing the targeted cementoplasty. So you can see here, there's a big fracture over here, vertical fracture. In this patient, the fracture was moving with the breaths. This fracture was moving with the breaths. So in this case, what we can do is we can go and target the cleft over here. We can fill the cleft over here first, and then we can start filling the entire body. So this is called a target cementoplasty. Again, you can see this is a hemangioma. So hemangioma is painful. Hemangioma is one of the cause of the chronic back pain, especially in the dorsal spine. You must have seen these kind of hemangioma incidentally, but all these hemangiomas are not painful. But if it is painful, we can go inside, we can fill this hemangioma with the cement, and we can just burn this hemangioma with the cement and also stabilize this vertebra body so that it doesn't fracture in the future. So this is how we can go with the fluoroscopy guidance, and we can target the hemangioma over there. Look at this. There's a big cleft fracture over here. Now you can see here, this piece is separate and this piece is separate. These kind of fractures will not heal on their own because there's a big gap between them. So in these cases, we can again go like this. We can target this fragment. We can target this cleft. We can go inside, start filling this cleft. Look at this. This is how we can fill the entire cleft. So with these kind of fractures, with the cleft fractures, earlier we used to do these kind of fixation surgeries, but now that is not required. We can go with the targeted cementoplasty and we can address these cleft. Look at this near complete collapse vertebra. Now, if you can appreciate this, there's a vertebral body over here. This is a normal vertebral body. This is again a normal vertebral body. But look at this vertebra. What is happening here? This almost completely collapsed. Now, this is painful because there's a big cleft over here. Obviously, we cannot increase the height of these kind of vertebra. That is not possible. Even if we try to do it, we will end up into complications. So what we have to do is we have to give the stability to the spine. How we can do that? We just have to fill the cleft over here. So with these kind of advanced trocars, we can go inside, we can target them, we can go there and we can start filling this cleft over there. So look at this. What we have done is we have filled the entire cleft. This is, we can see here, with a small hole. Again, these procedures are done under local anesthesia. We can discharge the patient same day after 4 hours of rest. We can do this kind of procedure at 1 level, 2 level, 3 level, but not more than 3 level in one go because cement fixes very fast. You may not be able to inject in all the 3 levels. Spinal pain pumps. So these are the implantable devices. These are mostly used for the cancer pain patients who are having severest of the cancer pain, who are in their terminal stages or maybe having low life expectancy. In those patients, we can put up pumps which are directly delivering the drug into the spinal canal. That means into the interthecal space. So this delivers directly to the target for the severest of the pain and spasticity. So this is also used for the spasticity where we use baclofen. For pain, we can use fentanyl or the morphine. We can fill these pumps with the fentanyl or morphine, and that they will deliver to the directly into the spinal canal, so that we can control their pain. So again, before implanting these kind of devices inside the body, we have to make sure that patient will respond to these implants. So for that, we do trial pumps, the trial intrathecal drug. That means we just gave 1 milligram of morphine intrathecally to the spinal root. We observe the patient for 24 to 48 hours just to see the side effect and the control of pain relief. If the patient says, I'm having more than 50% of the pain relief, then we go ahead with these kind of implants. So this is a kind of implant. Again, you can see here, there's a small port over here through which we can fill this implant. Once it is fitted inside the body, we don't have to take this implant outside, because this is a capacity of 30 ml, 40 ml. This may end in 3 months or 6 months, depending on the requirement of the patient. So we don't have to take out this to refill this. We can do it through the subcutaneous. We can see this port from outside and we can refill it from outside itself. So this is the kind of implant which we can use to fill. This is what we are doing now. You can look at here. This is the intrathecal route. What we are doing, we are just giving first the trial dose, that is just 1 milligram of intrathecal. Once we are confirmed with that patient will respond to this, then we put a catheter inside. So this is how we put a catheter inside. You can see there, big cannula over here. You can see the CSF will start coming out. We put a cannula inside. This is a catheter which goes inside through that cannula. We block this, and then we fill this pump with the morphine, 30 ml, 40 ml, depending on the size of the implant. And then we make a incision over the anterior abdominal wall, and we just put it inside the anterior abdominal wall. This is where we are going to place it. So now this pump is connected with the spine through this small tubing. So this pump will keep delivering the drug on its own. So we can adjust the drug doses also from outside. We don't have to remove this pump to adjust the doses. We can do this programming from outside. If the patient requirement is more, maybe after 6 months, after 2 months or 3 months, if the patient says, I'm not having good relief now, I need more doses for this medicine. Suppose if you have set it for the 0.5 milligram per day for 24 hours, if you have to change, you can make it 1 milligram per day also. So these are the spinal pumps. The latest advancement is the regenerative interventions. I think we all know about the stem cell therapies. Stem cell therapies are mostly they are used clinically for the oncology purpose and some other purpose people are using. In India, it is only allowed for the bone cancers. Not for any other purpose, we can use it for the clinically. So that is one of the restrictions what we have in India. I don't know about Ethiopia. If you have any restrictions over there for the use of stem cells, but we do have some restrictions with the use of stem cells. But nowadays, recently we have started using them for the degenerative condition for the joints. So these are the various therapies what we can use for the spine and the joints, that is PRP and the growth factors. But PRP and growth factors and the prolotherapy, these are the reparative procedures. That means they are repairing the damaged tissue with the fibrotic tissues, not with the normal tissues, not with the normal cartilage. That is the limitation with the reparative therapies, that means PRP and growth factors. But with stem cells, we can replace the damaged tissue with the normal tissue. So here what we are getting is the bone marrow derived stem cells. So we have just got an approval from the government of India in September 22 only for the knee osteoarthritis. Radiofrequency RF procedures, we must have heard about these radiofrequency procedures. So these are again the procedures which we can use for the for the severe arthritis and the nerve pains. If you have heard about these neuralgias, trigeminal neuralgias, facet arthropathy, knee osteoarthritis, so in those patients with the severe arthritis, where the surgery is not possible, whether the patient is not willing for surgery, or at times what happens is that patient is not fit for surgery. Patient is a candidate for knee replacement, but patient is not fit for surgery, medical reasons, or patient is not willing for surgery, and they are having severe pain. So in those cases, what we can do is we can use radio frequency and we can start denervating the joints. We can denervate the joints. That means we can ablate the nerves which are supplying that joints. We cannot ablate all the nerves, but we can ablate few of the nerves so that we can reduce their pain severity. So that is the radio frequency which we can use. This is the radio frequency machine what we have at our hospital. This is called a cooled RF technology. We have this conventional RF, pulse radio frequency, and a cooled RF technology all in one machine. So this is the machine which is we can make 4 lesions in one go. So RF we can use for the spine, for the facet arthropathy, for the disc, as we already mentioned about the discogenic pain, for the cervical facet joints. We know that cervical facet is one of the notorious joint, and a patient who comes with the neck pain, cervical spondylosis, these are the patients who are having severe neck pain, and these are the patients who will say that I'm having spondylitis, neck pain since last many years, and I've tried everything, all the medications, all the physiotherapy, all the other therapies, but it is not helping me. So these are the patients who may respond to these kind of radiofrequency ablation of the denervation of the facet joints. So these facet joints are there in the cervical region, in the thoracic region, and in the lumbar region. So we can do these RF procedures anywhere in the spine. This is the bicoplasty, which we already discussed, where you can do annular repair with the cooled RF technology. This is for the sacroiliitis. Now at times what happens, sacroiliitis patient, they will have severe SI joint pains because of the severe degeneration of the sacroiliac joints. In those patients, simple intra-articular injections may not work. In those we have to go for the fixation is one option where we can go for the fixation, but that is again a very tedious procedure. In those cases, we can go with the denervation of the sacroiliac joints. So this is how we can use for the knee joint, or the hip joint, or the sacroiliac joints if the patient is having severe arthritis and the patient is not responding to the medical management or the other interventions. Similar, we have heard about this trigeminal neuralgia. Neuralgia, as we know, that it is abnormality in the nerve signals which starts generating the pain. We don't see any abnormality most of the time. It is idiopathic. In those cases, earlier we used to go for the brain surgeries, neurosurgeries. We don't have to go for that. We can go with the radio frequency through this foramen oval. We can go inside the brain and we can just ablate these nerves through the radio frequency probes. So that is all from my side.
Yeah, so I think it was a very clear presentation.
Thank you so much.
Yeah, so thank you very much, Doctor, for taking the time to share your knowledge and skills in our platform. We also thank HBG Medical Assistants for the collaboration. So Dr. Kritika and Dr. Pankaj, thank you very much. And if you have any last remarks, let me give you the chance.
Thank you, thank you, all the participants. I hope you have understood this. What I can do is I can share the presentation to you. Maybe you can circulate to them. If they go once again through the presentation, maybe they can understand it better. If you want it, I can do that.
Yeah, we would love that. We will
Sure.
share it to our participants in our Telegram channel.
Thank you so much. So Kritika,
Thank you,
Doctor.
Doctor.
Presentation to you.
Thank you so much, Dr. Pankaj. It was a very brief presentation. Like, I think so everyone enjoyed it.
Thank you so much, guys. Thank you so much.
Thanks, Adam.
Bye-bye.